All right, so we talked about checkpoint inhibitors in frontline, how there are 5 checkpoint inhibitors and PARP combinations. We talked about atezolizumab being combined with bevacizumab, but there's an opportunity to get checkpoint inhibitors approved in recurrent disease, and that's what we're talking about. You saw at ASCO, why don't you tell us, the results of Keynote 100 and this idea that maybe single agent pembrolizumab might work in what you presented very, very wonderfully based on the number of lines of therapy and the PD-L1 combined score.
So thanks, Brad, for that. So I think if you take all comers of women with recurrent ovarian cancer, and again, indiscriminate use of checkpoint blockade, the response rate is about 8 to 10%.
Not enough for accelerated approval.
Not enough for accelerated approval. And I think, importantly for the audience, not enough to give a patient off-label.
Off-label.
Right, and that
Even
does
though it's
happen.
done.
Even though it's done. These drugs do have, obviously, toxicity. Right. So in Keynote 100, large trial, nearly just a little under 400 patients. There was a training set, then a larger set. Splitting patients into, as you said, patients who are less heavily pretreated versus more heavily pretreated. And the bottom line is, in both of those groups, the response rates, all comers, were about 8%, regardless of histology, regardless of number of prior lines. But that when you pulled out the patients who had something called the combined positive score of 10 or higher, so in a lot of trials, CPS scores of 1 or higher are considered positive.
Cervical cancer now
That's
approved.
right, cervical cancer, that's correct. But in here it was 10 or higher. So that's the number of PD-L1 positive cells over the total numbers of cells.
And only about a quarter of patients.
It's very low, exactly, that's right. And then there, the response rates were, around 20%.
So is that an accelerated approval opportunity?
Well, that's a very good question. That I think that it's not up to me. It is up to the company who
Another
sponsored the trial.
accelerated
Yeah, exactly.
approval opportunity for pembrolizumab in recurrent ovarian cancer with a CPS score greater than 10. Obviously, we don't know. That would be a pembrolizumab manufacturer opportunity.
Because that, again, that is regardless of number of prior lines, so that you would be able to sort of
But the
fill
level
an
of
unmet need.
the level of, this is your quoting you, which is my favorite thing to do. The level of false discovery is high because you're doing all of these various analyses and you stumbled on a small subset, maybe only a quarter of a patient where maybe it works. It's not the typical accelerated approval approach when you do 400 patients and try to find something in there that maybe works somehow.
Yeah, I mean, the only other piece of information going forward is in that other cancers, that level of CPS score, as it goes up, the response rates tend to go up as well.
So the challenge, I think, is that if you look at the 3 predictors of checkpoint sensitivity, if you look at tumor-infiltrating lymphocytes, which is only present in about half of ovarian cancer patients, if you look at PD-L1 expression, maybe only 2/3, and PD-L1 expression is a negative prognostic factor, actually. And then certainly the mutational burden, which is also exquisitely low, except maybe in the clear cell. We don't have it. And people say, well, ovarian cancer is a cold tumor.
Correct.
And if it's a cold tumor, I think we want to give chemotherapy to create an immunogenic cell death. So tell us about Javelin 200, the avelumab PLD study, which is interesting to test that very hypothesis.
Yeah, so obviously that's a hot trial.
No pun intended.
Good point. We expect those results in not too distant future, so we're very excited about that. And it has the potential, sort of, other than the Keynote study, of sort of cementing in the role of IO in ovarian cancer. So it's a very important study. It's a study that tested the immune checkpoint inhibitor in combination, in comparison to Doxil and or pegylated liposomal doxorubicin, and in combination. And those are interesting agents because there's been a lot of data for a long time about that particular drug in terms of what it can do to modulate the immune response. And so I think those combinations...
Some ADC opportunities, which is unique.
That's right. And so I think the challenge with 200 is this is an implantation-resistant patient population. And always the argument has been that's a population where are the T cells or the immune system really happy after having undergone all of that chemotherapy. we're kind of moving away from that belief. And so I don't know what the results of the study is going to be, but we're excited about
It's an important trial.
So Javelin 200 is platinum-resistant recurrent ovarian cancer up to 3 lines, all comers. PLD alone, avelumab, PLD avelumab, 550 patients, actually enrolled 560. And your Keynote 100 showed that heavily pretreated patients didn't really do worse. There was really
That's
no
correct.
T-cell exhaustion.
That's right.
And the results of Javelin 200 or Keynote 100 CPS 10 could be the first approval of a checkpoint inhibitor in ovarian cancer, maybe both. And your result was presented at ASCO, and the Javelin 200 avelumab result is imminent.
That's right.
So that's very exciting. I've talked to you then about Javelin 200 is imminent. You've mentioned that Forward 1 is just around the corner with mirvetuximab.
First quarter.
You've mentioned that Payola 1, now frontline bevacizumab olaparib, and then also Prima, all-comer HRD maintenance niraparib. So that's 4 studies, Javelin 200, Forward 1, Prima, and Payola 1, which will all report in the next 6 months. We're going to have another online.
No, it's true. No, you're right.
That's the fun of it.
It's going to be a good time.
It's really exciting time. Yeah, and it's exciting from just obviously all the trials you just mentioned, but also the increased level of interest of researchers, pharma, and really understanding that yes, we can improve ovarian cancer treatment.
And again,
that wasn't present 4 years ago.
Because the prevalence, though, is 10 times the incidence.